This session was recorded on the 21st of July 2022 as part of the National Cancer Patient Experience Survey 2021.
So I'm the National Programme Lead working on the National Cancer Patient Experience Programme at PICA, and today we'll be taking a look at some of the key areas of focus in the CPES 2021 quantitative findings. So there's a full set of reports for the 2021 results at National, Alliance, ICS and Trust level, which are available on the CPES website. And just to draw your attention to a few things that are new for 2021, we've got an easy read version of the national report, a thematic report looking at the qualitative results of the free text comments. We've also got ICS reporting, which for this year replaces CCG reports, and you can also explore the results more using the interactive tool that's available on the CPES website. So the survey has not been reviewed since 2015 when the last full review took place, and for 2021 the survey was updated as there had been significant changes in service delivery, clinical practice and policy, which the survey now reflects. The CPES advisory group oversaw the review of the questionnaire, and as such, you'll have noticed for 2021, there is no historic trend data in the 2021 reports. So who's eligible? All of the NHS trusts in England that provide acute and specialist cancer care are asked to provide a patient sample. And within this sample, all patients who are aged 16 and over with a primary diagnosis of cancer will make up the sample. The sampling period for last year was between the 1st of April and the 30th of June and will be very similar, in fact, exactly the same for 2022. And last year we yielded a response rate of 55%. Also, it's just to note, it was touched on before, but outpatients are not included in the patient sample that we work with currently. So we're going to just touch on a couple of the questions from each section that have been selected to provide an overview of the experiences across the cancer care journey. And we'll touch on a few of these here and then in a little bit more detail on a couple of the sections further on. So overall experience, as Kynwen and David have already said, when asked overall, how would you rate your care with a scale from 0 for very poor and 10 to very good, 94% of respondents rated their overall care experience between 7 and 10, and 6% rated it between 0 and 6. As we heard from Kynwen, the respondents from white ethnic backgrounds gave a higher average rating of care than respondents from mixed Asian and Black ethnic backgrounds. And then reflecting slightly as well on the finding out that you had cancer topic, we had a 71% of respondents say that they were given the option of having a family member, carer or friend with them when told that they had cancer. So a good result, but again, some improvement to be made in that area. Moving on, deciding on the best treatment. So when asked if they were involved as much as they'd like to be in decisions about their own treatment, 79% of respondents said that they definitely were. And then when on the survey, support from a hospital staff, 90% of respondents said that hospital staff gave them the information that was relevant to them about the support for people with cancer. Looking at hospital care, of those who stayed overnight for cancer care in 12 months prior to receiving the questionnaire, 81% said that they had confidence and trust in all of the staff that looked after them. But when looking at immediate and long-term side effects, only 60% of patients felt that the long-term side effects were definitely explained in a way that they could understand and in advance of their treatment. So outside of the hospital, as highlighted by Kynwen earlier, an area that showed quite large gaps and evidence of gaps in support available for people with cancer was care from your GP practice. So of those who said that the GP practice was involved with their cancer treatment, less than half, only 44%, said that they definitely received the right amount of support. So just to touch on a few of these areas in a little bit more detail. There were both positive results and areas for improvement in people's experiences of finding out that they had cancer. Just under 3/4 of all respondents said that when they were first told they had cancer, they'd been given the opportunity to have a family, friend, member or carer with them. And of this group, it was the age 16 to 24-year-olds that were most likely to say that they'd definitely be given the option, with the age group that we spoke about earlier of 35 to 40-year-olds less likely to say that this was the case. Also, interestingly, respondents with dementia or Alzheimer's were the most likely, to say that they'd been given the option, but respondents with mental health conditions were the least likely to say that this was the case. When asked patients how they felt about the way that they were told they had cancer, 74% said they were told in a sensitive way, and 84% told us that their diagnosis was in a place that was appropriate for them. So hospital care, looking at people's experience of hospital care, people treated for cancer in England did report generally positive experiences of care in the hospital, according to this year's results, with 89% of respondents saying that they were always treated with respect and dignity whilst in hospital. Out of these respondents, males, as we heard earlier, were the most likely to say that they were always treated with respect and dignity whilst in the hospital, but respondents who preferred not to say when asked about gender were the least likely to. And out of this, 86% of respondents saying hospital staff did all they could to help control pain. Furthermore, with hospital care, some areas of hospital care had a lower experience rating for the respondents. So personalisation and person-centred care, which are really key policy priorities and important for patients and users, were lacking in some places. For example, only 70% of the respondents said that they were always involved in decisions about their care and treatment whilst in hospital, meaning that 30% of respondents felt that they were not involved as much as they'd like to be. And 6 out of 10 respondents who stayed overnight said that family or friends are close to them were definitely able to talk to someone on the team looking after them when they needed. 67% of respondents answering that during their hospital stay, they could always talk to hospital staff about their worries and fears if needed. And of those respondents, it was those whose cancer was treated without any sign of further problem that were more likely to agree with this statement. Looking at care planning. So when asked questions about how they were supported with their cancer care, 93% of respondents had a discussion with staff about their needs or concerns and said a member of the care team helped them create a care plan to address that. And 99%, which is a brilliant result of respondents who had that care plan, responded positively, saying that a member of the team looking after them helped them to review it and make sure it continued to reflect their needs and concerns during treatment. Looking at support from a main contact person. 85% of respondents found it either very easy or quite easy to contact their main contact person, with respondents from white ethnic backgrounds the most likely to experience this, whereas again, respondents from ethnic backgrounds, Asian ethnic backgrounds, the least likely. 9 out of 10 respondents said that they had a main contact person within the team looking after them who would support them through treatment. And of that, 96% of them said they found their advice from the main contact person to be very or quite helpful. So support while at home. So an area of response that revealed another lower experience rating from patients was support whilst at home. Only 55% of respondents said that their family or someone else close to them were given the information they needed to help care for them at home. And respondents with breast cancer tumours were the group least likely to have a positive experience rating, with only 48% in this area. Respondents with a mental health condition were the least likely to say that their family or someone else close to them were given all the information that they needed for the team looking after them. Care from your GP practice. So as we heard earlier, another area of response that showed a lower level of care satisfaction was outside of the hospital with the care from your GP practice. Of those who responded that said that the GP practice was involved in their cancer care treatment, 44% said that they got the right amount of support from staff at the practice where they were receiving treatment. And respondents in the most deprived group, based on IMD quintile, were the least likely to say that they got the right amount of support. 18% of respondents said that they had to review of their cancer care by a member of their GP practice, which is one of the lowest results that we have from the survey. So for any further guidance on scoring, suppression and how that's been supplied and how to use the reports, please do refer to the CPES website, which is just on the slide there, and you can look at the technical document which is listed on the website. You can also ask questions in a moment to myself and the rest of the team, or you can send an email to the CPES email address, which is also given there. Before I stop sharing my slides, just say a big thank you, and if anybody's got any questions, please to let us know.
Thank you very much, Philippa. There are a number of questions that are popping up into the chat, so I do just want to take a pause before we move on to explain, to answer some of the items that are coming in here, and I'm going to call on others to support with this. First of all, there are some questions about the technicalities of the reports and access to frequency tables. Those are all available to download from the CPES website, so please feel welcome to access that. There's also a number of questions around kind of subgroup analysis and what is going to be available. Jenny has popped a response in there saying that we are going to be releasing additional data that is available as it comes out. There's also specific queries about certain questions. Very much welcome this feedback. I think I speak for the team on this, where we're always really keen to hear people's feedback on the questionnaire. We are noting down what is in the chat, but please, if you think of anything at a later date, contact cpes@picaeurope.ac.uk, and we'll continue to collate and engage with that feedback. There are a couple of questions I've just seen responses going on to here. Is there a plan to include outpatients in future surveys? I think, David, you gave the best response to this. Yes, there are plans, but it is not quite as straightforward as it sounds. Claire, I know that you have highlighted Terry to maybe provide some update as to how that is going at the moment.
Terry's answered in the chat box, Hannah.
Excellent. That's an excellent response that we have got there. Is there any work being done around demographic associations, i.e. scores from Black women, not just one demographic? Jenny, could you come in and talk a little bit about some of that additional analysis that is ongoing?
Yeah, so that will be the update that we're making to the online reporting tool, hopefully by the end of August. That'll just be at a national level for this year, but there are plans to extend that for 2022 onwards. And that update will allow you to see that exact example, actually, so scores from Black women or white men, etc. So we'll let everyone know once that's available so you can go and have an explore. But I think that just adds another level of detail to help people understand kind of types of interactions between subgroups and different people's experiences.
Thank you. I am going to move on to explain, Kirsty, if you're happy to drive your own slides there. And we're going to be focusing here on some of the qualitative free text data that has come in and some of the combinations.
Can you tell me if you can see the slides?
Yes, we can.
Perfect, thank you. So hi everyone, my name is Kirsty. I am Associate Director at Explain, and we have been delighted to undertake the analysis of the open-ended questions for this year's survey. And I'm just going to give you a very brief overview of the findings today. If I can move the slide. There we go. Right. So we have, I'm just going to give you a very whistle-stop tour of our methods because our time is limited. We undertook thematic analysis. So what we've done is we've allowed themes to emerge from the comments. We haven't applied any kind of a priori analysis. There were, for your information, there were 3 qualitative questions asked within the survey. They were asked, how would you describe your care and treatment? Then, was there anything that could have been improved? And there was a 3rd question, which was, do you have anything else to tell us? We haven't analysed the responses from, do you have anything else to tell us, any other comments, because they were just highly repetitious of what was in the first 2. In order to present an overall thematic analysis, we've merged responses from both question A and question B together. The sampling that we undertook was a kind of a 2-pronged approach in order to make sure that we had a statistically representative sample from the overall survey. We analysed the responses from a sample of 1,501 respondents, and then we also ensured that we reached data saturation, and that's the point at which we knew there were no more themes emerging from the data. And I think it's important to note that had we got to the end of the 1,501 and not felt that we'd reached saturation, we would have continued to sample. So now I'm just going to go on to the actually interesting stuff, which is the findings. And I think a lot of this is kind of, I suppose, going to reiterate what's already been mentioned in the first few presentations within this, and that is the overwhelming finding, which is something that I think it's very important to situate all of the qualitative analysis in, was one of gratitude. We had a huge number of comments expressing gratitude for their care, and in particular, respondents mentioned kindness and compassion of staff. So words that were used to express this feeling of gratitude included being progressive, efficient, brilliant, outstanding. And this does echo very strongly what was mentioned in the experience overall in the CSAT. So having said that, there were some negative findings, and I think what we're going to do now is explore areas that people mentioned as areas that they could be improved upon. And the first one is, again, echoing what was found in the quantitative work, which was rounding negative experiences kind of with general practice. And respondents discussed 3 specific areas here. Firstly, a feeling that GPs may not have taken their initial symptoms seriously, and importantly, they felt that that led to a delay in their diagnosis, and that had quite a big impact on them and their experiences. They also discussed a feeling of a lack of proactive follow-up by GPs after diagnosis or treatment, and they also discussed difficulty with accessing GP appointments. So generally throughout the cancer experiences, there tended to be a negative view about the way that general practice and primary care was supporting them. Then moving on to quite a significant finding again, which was communications for patients. And I think it's important here to point out that at the bottom of the slides, we've brought out some quantitative data that marries or correlates to what we found in the qualitative data. And sometimes you may find that there was quite a high respondent in terms of the quantitative data that said that they found that they had effective communication, and yet we're bringing out as quite a significant theme. But what that means is that whilst there may not have been a huge number of people who talked about these issues, when they did talk about them, they tended to have a really quite significant impact on their perceptions of care. And I think communication is one area in which you can see that exemplified. Respondents talked about feeling inadequately informed about some aspects of their care, and they commented on a lack of effective follow-up. This really manifested particularly in, I would say, 4 key areas. One was really wanting to find some more detailed information on their cancer type. Then there was information regarding the type of treatment that they were receiving, information on the side effects of treatment, both short-term and long-term. And then also in particular with surgery, people talked about not knowing what they could do or not do safely after they'd had their surgery. And also in terms of communication for patients, there was a feeling throughout the themes that patients really had a desire for face-to-face communication. They acknowledge the need for telephone communication or virtual communication through COVID, but they expressed a desire to have face-to-face communication going forward, primarily because they felt that it was more appropriate to receive potentially distressing information, but also they found it easier to pick up on non-verbal communication with healthcare professionals and therefore have more effective communication in a face-to-face setting. And they also emphasise the importance of what has been termed within the survey as a single point of contact. And again, we know that the vast majority of people do have that single point of contact. It's just when they didn't have it, they expressed a very strong feeling that had they had that, it would have made their experience navigating their cancer journeys a lot simpler. Another key finding was around waiting times, and this was mentioned in many different contexts throughout the patient experience journey, going through right from starting treatment through to transport, through to the time when they're actually waiting for an appointment physically. But the most prominent example was waiting times that were longer than anticipated for diagnostic tests and treatment to begin. And for some, this wait was associated with poorer prognosis, in that they perceived that had they had things moved a little bit faster, they would have had a better prognosis. There was also talk about negative experiences with hospital staff. And again, I think it's really important to emphasise that these tended to be very strongly isolated incidents. So people would talk about, in general, having very positive experiences with staff, but on the odd occasion when they had negative experiences, they really stood out and had quite a significant impact on overall perceptions of care. So those isolated incidences tended to be around staff being unprofessional or inconsiderate, and a lot of the time there was a common feeling that staff were just too busy and the wards were understaffed, and that impacted on the care that they were receiving. And then finally, we drew out throughout comments, there were quite a lot of comments relating to wider hospital issues. Now, again, we know that these are not necessarily related to cancer services, and they may not be necessarily even something that people have a huge degree of control over. But we felt it was important to highlight them in the report and here, because when they were experienced, they still did have quite a large impact on people's experiences. And people did talked about having food quality and variety being quite poor, about issues about parking, lack of privacy on wards, and that was felt to be particularly important when discussing the difficult and sensitive issues that can emerge in cancer conversations, noise disturbances at night, the decor needing an update, and actually people talked about if they did that, then people would feel just a little bit more positive when they were on the wards, beds being uncomfortable, and restrictions linked to COVID-19. And that's just a whistle-stop tour of everything that we've done. And I think I just wanted to end by asking whether anybody had any questions.
Hi, Kirsty. That was really, really interesting feedback there. I'm going to echo Jennifer's point in the chat, which the qualitative analysis really helps to understand some of the data that has been presented here. Are there any questions for either Kirsty or Philippa about the national data results here? No, well, if there is nothing that comes up at this point, that is great to hear. I should say, echo again, all of the results are currently available on the NCPES website. So you'll be able to find out all of this information that is available here. And if you have any questions, please do not hesitate to get in contact with CPES at PICA Europe. Dawn, that was a handy hand that was coming in there.
Sorry, I just wanted to ask a question. So what I'm finding really difficult is to be able to filter the comments to the tumour sites so that we can feed back to the particular nurses relating to that area of the comments. And I know previously we've had comments, we've been able to do that, but it doesn't seem, I haven't been able to do that with these results.
Do you mean the
Dawn, oh, sorry.
Sorry, I think I'm probably going to ask the same. Are you talking about the quantitative data or the qualitative?
Yeah, the comments. Yeah.
The qualitative
Yes.
stuff.
Yeah.
So what we've taken is we've looked at everything as an overarching. We haven't looked for the qualitative analysis. We haven't drilled down to particular cancer types. We looked at people's comments, and effectively what you do with qualitative analysis is you let the data speak for itself. Had there been major differences in findings according to cancer type, that we would have reflected that in the analysis, but actually the comments overall tended to be quite similar. The people had similar experiences. Does that make sense?
I think the difficulty is, though, that if you do have a negative comment, you can't feed it back to that particular area if it's not telling you which tumour site it relates to. So previously when we had the comments, we could do that. So it would tell us which particular area the comment's related to. So for me, when I've got those results, somebody's made a negative comment about a service, but it doesn't, I have no idea which service to feed it back to. So it makes it really difficult to evaluate.
Is this your service level or the overall national stuff?
No,
Sorry.
the service level.
Service level,
Right. So, yeah.
So I think this relates to the free text workbooks, which are available for each of the trusts and were sent out with a password for you to kind of access, Kirsty. So that makes more sense.
Yeah, it does. I'll drop out of that one.
So I'll answer where I can, Dawn. The way that they work at the moment is that they aren't linked to the patient sample. So you can filter by cancer type or site, but it will only draw your attention to comments which have talked about that specific cancer type. So if somebody is talking about, say, breast cancer within their comment, then you will be able to filter within the spreadsheet to that and see the comments, but that doesn't mean that that was that patient's primary diagnosis. There is no link between the free text comments and the patient sample with the primary diagnosis of cancer that we receive from the trusts. Is that what you mean in terms of trying to relate
it
to?
just makes it
Okay,
really
this was
difficult to be able to feed it back to whoever it is.
Yeah, I
when
can see
we've
that.
no idea who it
We
relates to in terms of, it would be really good if it was linked to the tumour sites, because you know, it's helpful, but I wouldn't have a clue who to actually feed it to. I found them quite difficult to try and interpret. So unless someone's actually mentioned breast within their comment, you mean, we won't know what it is. So
yeah, it could
but
be that their
previously,
primary
when we've had the comments, it has been filtered down specifically to the tumour site, and that has been much more helpful.
Thank you very much for that, and it's something that we've definitely been speaking to NHS England about, and is something that we are reviewing for next year going forward. There is just maybe a slight discussion to be had around patient confidentiality, as it, you know, is an anonymous survey. So obviously, in terms of the free text comments and linking it, there might be, if it's something that is possible to do, it might be that some more suppression would be surrounding it. But yes, thank you very much for your comment. And you are right, at the moment, you cannot do that on the reports as they are. It's something that we're looking into with NHS England for next year.
I had emailed, but hadn't really had a response that had answered the question, so that's helpful. Thank you.
Diane, do you also have a question or comment?
Yes, I do. Thank you. So it's very, very similar to that question, but slightly different. So obviously we go away and we look at the detailed reports. So there's different levels here. So there's the national themes are likely to be in everybody's system. So because you didn't get that comment in our particular system in the East Midlands, so one of our providers, doesn't mean to say we haven't got that challenging area. So I think it's great to see the national level cut as well. But the bit that I'm unsure of is how on the qualitative, when you've just got a few comments, it's how do you prioritize? So normally what happens is we're doing a remedial action plan and address maybe 3 to 5 areas that we would focus on for a year to improve, and then measure it a year on and hope that that measure moves in a positive way. So how would we as an alliance or as an individual, the individual trust within the East Midlands Alliance, how would we know which area to prioritise? So which has got more weight in, I suppose, is my question, of the qualitative comments?
That you receive locally or nationally?
Well, that's why I started with the preamble, because they're all intertwined, aren't they? Because only one person put their hand up and said this isn't great here. In common terms, if they're signalling a problem with primary care or getting it will be across the system, won't it? It's likely to be across the system.
Somebody else may have a very different view here, a more informed view from within cancer services, but my advice as a researcher would be that you need to look at the overall picture. You can't look at quant and qual in isolation. You need to look at them together. And in your area, if you're getting quant that's showing you, for example, that I'm just pulling figures out of the air here, say 97% of people say that they have a single point of contact, but then you're getting a lot of comments relating to, I didn't have a single point of contact. The chances are that actually, whilst that's not a big issue numerically across your service, when it isn't there, it's having a really big impact. So you need to look at where it's not there and then marry your service development to that. Would be my, as a researcher, would be my general advice, that you need to look at them holistically together. It's not possible to just look at one in isolation.
So could I just ask the question, what was the criteria for the pointers that you included in the national slides just now? How did you cut them to being the important ones that went into the slides? What was the criteria?
it's thematic analysis. Are you aware? Are you familiar with that? Yeah.
So that everything we've seen, every single theme that came up, is that what you were saying on those slides?
You may have an odd comment that doesn't fit into any particular sense of meaning in that it, but the vast majority of comments will be encapsulated within those themes.
Okay, that's really helpful. Thank you.
Thanks, Kirsty. Thanks, Diane. Arena.
Sorry, just echo what people say, how you really make improvements as presented patient story. It's a huge kind of lever for us and impact for the MDT. But MDT will immediately ask, is it breast patient? Comment, is it brain patient comment? And while we're using exactly the same argument, Kirsty, you just said that you need to see what is really in issue as important for the team. We presented already to clinicians and we presented to patients, and people say, well, it's generic, we want to understand issue per tumor group. And before we could do this by pulling the comments per tumor group. And for example, we understood what patient mean to access to information and support for breast, completely different meaning for our colorectal team or colorectal patients. And that was really useful. So if we can't do this, it's kind of unfortunately losing a bit of meaning. And we did have quite a lot of criticism from patient voice group and from the clinicians who were presented at King's that we're actually unable to do this at this level. Obviously, we were able to do it before and not now. They felt that was a really negative kind of step to do it this way.
Thank you, Arena. It's really useful to have that kind of feedback about how the results are being used on the ground. That's very useful context for everyone who has brought this up. And I think I can speak for people on this call, the PICA team, and maybe to extend the NHS England team, we're suddenly hearing this feedback for the review of the reports. We want to make sure that they're as usable as possible on the ground. So this is really useful context to be provided. So thank you. David.
Hi, sorry, I don't have a camera on the computer that I'm on. I just wanted to say, I work at Manchester Foundation Trust, and I think one of the challenges, and I'd be really grateful for anything you can do to sort of help and support us, is that we have cancer services on multiple different sites, and we have multiple teams on different sites. So we've got like 3 lung cancer teams, we've got different breast cancer teams. I think our real challenge is trying to align the comments and the results for each speciality to which part of the service they might align to. And I don't know whether there's anything we can do with the results to break it down more by the hospital from which people have come, because that would be really helpful. Otherwise, I've just got like results that align to a breast service, but I don't know which part of the MFT services they really go to. I don't know if anyone's got any thoughts or comments about how I can use that and drill down into the data a little bit more.
No, thank you, David. Once again, good context. Philippa, were you popping in there?
Yeah, I was just going to say it's another request that we've had. We've had numerous requests for site breakdown again across hospital sites and how the data could be used more effectively. We've also fed that back to NHS England. I don't know if anybody from the team wants to come in at that point with how it works at the moment, but it's something that we don't currently capture with the survey, but it's something that we will look into probably from 2022.
And I know, Philippa, that obviously it can be challenging because it might be that a patient goes to different parts of the MFT system. So again, it can be challenging because they might have care on multiple sites of ours. But I think even just asking where was your principal site of care might just be really helpful. Just to be able to take it back to the teams and it make it a little bit more relevant for them in some way, as opposed to these are our collective MFT results. And I think also more helpful for kind of like my line manager and our sort of group cancer committee, just increase that relevance and just break it down a little bit better. But anything you can do would be really helpful going forward. So thank you.
Thanks, David. We'll definitely take that point forward.
Ian.
Yeah, hi, thanks. So my name is Ian Mackay. I'm the lead cancer nurse at Hillingdon Hospital. And just to kind of echo the points that's been put across. We notice with our comments that we're getting comments for other trusts and not our trusts as well. So a lot of our patients will go to a neighbouring trust where they will receive their oncology treatment. And so when you look at the results and the comments, they talk, it's very clear that they're talking about a different organisation to us, yet those results that are in the normal survey are reflected to our organisation. So it's always, when you look at our results, it's always a bit, you're not sure if they're talking about our trust or another trust because of that. So I think any way that we can look at how we can capture which organisation they're talking about, not just which site, but which organisation they're talking about, because often the patients, because they move around, get confused as to which organisation they're talking about, and they group the whole of the NHS as a whole.
Completely agree with this, Ian. And I know that steps are starting taken, and Philippa, you can talk about this, about highlighting which trust that we'll be talking about in the survey, but completely agree with your point that patients do get confused, and they're talking about a very long period of time with regards to care, and will sometimes provide feedback for other organisations there. Philippa, did you want to add anything?
No, I think that's, it's all things that we've heard and that we are looking to improve and working on. So just thank you. And if you've got any further, or if you've got any other suggestions of how you think it might be able to be captured, then please do share it via email with us.
Fungusai.
Everyone, I'm Fungi. I'm Macmillan Lead Cancer Nurse in North Warwickshire, George Eliot Hospital. I'm just going to pose a question really surrounding the site-specific data. We are a small hospital, so our sample size is always very small. So when we want to drill down to the site-specific feedback year on year, we have a difficulty because some of the data is not statistically viable. So there's always a star or an asterisk against that. But is there a way of navigating that round? So even though we know it's not statistically viable, of at least getting some of that feedback, because we only have 2 tumour sites, the bigger ones that get enough data from the National Cancer Patient Experience Survey, for that is site specific. So is there anything that we can do surrounding that? Because smaller hospitals are always going to have this problem.
Thank you. Philippa, is this something that you can help with?
Jenny might want to add a bit more to this as well. It's surrounding the suppression that we have to apply to the data that unfortunately results in some of it being hidden for some of the smaller trusts. So we do have the suppression rule if it is under 11, and that has been changed. I think it was, somebody might want to jump in here, but it was definitely over 20 before. So we've already reduced the figure in order to try and share more data with the trusts. It's something we're aware of. I don't know myself of a workaround at the moment, I'm afraid. As I said, if anybody from the data team has any idea on that, or if you want to follow up with Fungi with us via email, we can sometimes do some ad hoc data drilling down for you on kind of specific site cases. So you can always send us an email and we can explore that, whether or not that's an option for you.
Thank you.